All right, there may be a few folks still joining us, but we're going to go ahead and get started. Welcome, everyone, and thank you for joining us for today's Dream Research Rounds. We're so glad you're here. The Dream Research Rounds are designed in the spirit of traditional grand rounds, offering monthly sessions that spotlight research and research teams from across the country and around the world, all focused on disability and academic medicine. This series is sponsored by the University of Illinois College of Medicine, Department of Medical Education, and we are deeply grateful for their ongoing support. My name is Allie Martin Schofield, and I serve as the Chief of Staff for the Docs with Disabilities Initiative. On behalf of the entire Docs with Disabilities Initiative team, thank you for being part of this community and for making space for scholarship that centers equity, access, and learner experience. Today's Dream Research Rounds will review the paper Food Insecurity Among Medical Students, Survive versus Thrive, a timely and important examination of how food insecurity shapes medical student well-being and educational outcomes. It is my pleasure to introduce today's presenter, Bassel Shanab. Bassel Shanab is a medical student at the Yale School of Medicine. He earned a Bachelor of Arts in Biological Sciences with a concentration in Biochemistry and Biophysics, as well as Global Health Studies from Northwestern University, graduating with distinction. Prior to medical school, he conducted translational research on arterial fibrillation under Dr. Rishi Arora at Northwestern University's Feinberg School of Medicine, and served as a teaching and laboratory assistant in the Department of Biological Sciences. Bassel's academic interests include cardiovascular health, social determinants of health, health disparities, health policy, and healthcare administration. At Yale, he has served as a co-leader of the American Medical Student Association chapter and the first-generation low-income medical student affinity group. He currently serves as his cohort's financial aid representative, a representative to the AAMC Organization of Student Representatives, and a member of the Health Equity Thread Advisory Group. Nationally, he holds an elected position as the Northeast Delegate for the AAMC OSR Community and Diversity Committee. We are grateful to Bassel for sharing his work with us today and look forward to a rich discussion. Bassel, I'll turn it over to you.
Hi, Allie. Thank you so much for that wonderful introduction. Hello, everyone. It's my pleasure to speak here today for January's Dream Research Rounds, discussing medical student food insecurity. To introduce myself, my name is Bassel Shanab, and I'm a fourth-year medical student at the Yale School of Medicine. The title of the talk today is Food Insecurity Among Medical Students, Survive versus Thrive. I have no disclosures or conflicts of interest in relation to this presentation. Now, to begin, we should establish a key definition. What is food insecurity? The USDA utilizes the following definition. Food insecurity is the limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. What does this look like? These are some of the examples adapted from the USDA's Adult Food Security Survey module. You can see they have an underlying implication of the cost and affordability of nutritious food. Next, I want to put this into the context of a medical student's reality. What can food insecurity medical students look like? Looking to qualitative studies that have highlighted how medical students experience food insecurity, from eating unhealthy food when facing time, transport, or cost barriers, opting for fast food over a balanced meal. In addition, students report relying on irregular sources of food, like a campus lecture series or a didactic series on a rotation in a hospital, or having their resident or attending team cover for them. Students have also described sleeping more and exercising less to mitigate hunger pains after a long day. Now that we've defined food insecurity, how many students are food insecure? Studies by our group have estimated that 23.8%, or nearly 1 in 4 medical students, are food insecure from our nationwide multi-institutional surveys, the latest done this past academic year, 2024 to 2025, including 30 medical schools. The prevalence of food insecurity at 23.8% is near double that of the average American household, the latest this past December at 13.7%, placing medical student populations at near double the prevalence of the very same communities that they serve. But which medical students are food insecure? It's not evenly distributed. Our studies have shown that students of historically marginalized backgrounds were more likely to be food insecure. In particular, these are students who are from backgrounds underrepresented in medicine, who face a prevalence at near double that of their peers. Students with disability were also more likely to be food insecure, 1.5 times that of their peers. Students who are trans or gender diverse were similarly facing high rates of food insecurity, as were students who were low income relative to their peers. We found that students with parental support in financing their medical education were less likely to be food insecure. I just want to take a pause to allow us to reflect on that. These identities are not in a silo. We as individuals carry many things on our shoulders. And what we see here amongst medical students is a number of different varying prevalences that were analyzed in a one-dimensional way. But our next slide will look at what people have been experiencing, the reality of their day-to-day, as we move to encapsulate who they are, their role of intersectionality. Finding that students with multiple marginalized identities faced compounding rates of food insecurity, as illustrated here. You can see that students with a disability who identified as underrepresented in medicine from a low-income household had a near 4-fold risk of food insecurity relative to a peer who did not hold any of these identities. As you can see here from this wonderful illustration in one of our papers, the compounding risk associated with holding multiple marginalized identities. Medical school is not a journey you want to perform on an empty tank. From the intensive preclinical phase to demanding clinical schedule, although there are way stations, it's not the most forgiving adventure. From students concerned about not performing well on standardized academic exams to not putting out their very best on a clinical rotation. What is the impact of food insecurity on medical students? Let's start with their well-being. In a national longitudinal cohort study, the LEAP study, food insecure students are more likely to be anxious, depressed, burnt out, and report a low sense of belonging. So let's take stock in what we've discussed thus far. We've established that there are nearly 1 in 4 medical students who are food insecure, that it's not evenly distributed as to who is food insecure, and that food insecurity is not a benign problem to be experiencing. Students are facing higher rates of anxiety, depression, burnout, and a low sense of belonging. That's not evenly distributed, and on their own already disproportionately affect different student groups, the same students who are also suffering from food insecurity. So let's discuss what students have shared in qualitative studies with both myself and colleagues. Beyond the direct impact on their well-being and sense of self, our work and that of colleagues have shown that students experiencing food insecurity struggle to be present in the academic setting, particularly for students of historically marginalized backgrounds like first-generation low-income college students. Food insecurity can heighten imposter syndrome. To define that, that's the self-perception of being an other or not truly belonging, especially in a field like medicine, often characterized with much prestige and wealth. Students report suffering from food insecurity alone, despite other students being in a similar camp. Some students have reported frustration with their efforts to mitigate food insecurity, coined as resilient by those with authority and power at their medical schools or in society. Whereas other students have reported relying on meals sourced in an uncomfortable way, dating for food, theft of meals. Taken together, medical students suffering from food insecurity face an arduous course, navigating the already difficult challenges of medical school and struggling to meet other basic needs like housing, transport, and academic resource affordability. Ultimately, the literature I've shared with you suggests a potentially vicious cycle that perpetuates itself as these students suffer without their own basic needs met, and they're often doing it alone. Further work is needed to better understand how food insecurity contributes to poor academic performance and attrition. But students have already discussed at length when they're hungry, they're not able to focus. They definitely can't be present. And competing financial priorities place them in a position of choosing if they're going to eat or if they're going to put shelter over their heads. I want to discuss further why these students in particular, why are they placed with the extra burden of food insecurity? I want to just go back to what I had shared earlier about those examples from the USDA. When we think about these particular students, they're often facing more of a financial burden than their peers. Students from historically marginalized backgrounds are disproportionately experiencing food insecurity, but they're also students who are more financially vulnerable than their peers, suggesting that there's a misalignment of estimated cost of living and those students' reality for food insecurity. The research has shown that students from backgrounds underrepresented in medicine and low-income households may be financially responsible for their own dependents or serving as caretakers for adult family members. More so, students with disability have also reported greater costs of living, not only due to their own medical expenses, but to the cost of accessibility, to access a grocery store, to receive meals relative to their own dietary needs. These students already are set up with a financial burden and then experience food insecurity, possibly because there's a misalignment of their estimated cost of living by their medical schools and the reality in which they live. What can we do about that? Given the majority of students are struggling with food insecurity, in part because of budgets that underestimate their own reality, one would argue that we'd adjust their cost of living accordingly. These students would simply just demonstrate to their financial aid officer that they have other expenses. A financial aid officer of reasonable background would go and analyze and review and approve those. Often, these students would have this increase in their cost of living be an additional loan up to the full estimate of cost of living if the student didn't borrow as much, or an emergency loan of a smaller amount, depending on how much the student has already borrowed. And if possible, these students normally would be evaluated for their ability to receive assistance from the Supplemental Nutrition Assistance Program, SNAP, also known as food stamps. This is not possible in all states due to eligibility criteria differences for students, requiring that they work at least 20 hours a week or on federal work study. However, this burdensome process is a barrier enough, even for those eligible. Just as an aside, a governmental analysis done had found that just 41% of food insecure SNAP eligible college students were actually utilizing SNAP. Again, to repeat that, these were students who were eligible. They met the work requirements. They also were food insecure, which is not a necessary condition. These students were already in need and financially were eligible, and yet only 41% of students accessed SNAP, in part due to the barriers of applying. Now, with what I shared, all of these suggestions have changed in the last year. The One Big Beautiful Bill has placed a lifetime loan cap predicted to disproportionately affect these students already facing a large financial burden, in part to many things out of their control, financial responsibilities that they carry for their families, for their communities, for themselves. And as a result, they are experiencing food insecurity, but they cannot request an increase in their financial aid due to a loan cap for their lifetime on graduate and professional students, beyond other policy changes made in the One Big Beautiful Bill. Research has shown that this again would disproportionately affect these historically marginalized students, perpetuating the same cycles we've observed over the last few slides. In other words, these students cannot borrow as needed. They must further budget and decide what basic needs they may need to go without. In addition, as to SNAP, if you did recall this past November, SNAP eligibility has become more stringent with state funding changes as well as less assistance to anyone in completing an application. To be particular, requirements were changed for able-bodied adults without dependents, which are commonly graduate and professional students. So let's redesign this slide. What can we do realistically? How can we support medical students or any student or any community member, really, for that matter? There's a various number of things that we could do starting today. We could start a food pantry to work hand in hand with our community, supporting local farmers for community-sponsored produce boxes. We can offer students resources to offset other costs in their medical education. Now, to be clear, each of these things have pros and cons, and let's take the time to nuance them. Food pantries are a band-aid, but it offsets a budget, and it's relatively quick to implement, especially for shelf-stable items or non-perishable things that people don't necessarily eat, like hygiene products. We can provide those to people today. On to the more complicated solutions. University dining systems and hospital cafeterias. These enterprises that maintain excellence in medicine also hold the secret for how we can help others, both within our community and without. From leveraging student discounts at a hospital cafeteria to preventing substantial food waste, we can redirect food that otherwise would not be eaten to students in need. And those are solutions that are done across this country, both at the university level or at the hospital level. And lastly, community partnerships that also may result in savings and stronger bonds with the very same people who keep our produce systems safe, secure, and nutritious. Now, let me talk through some of the innovative work ongoing with our partners at the current national network for flourishing in health to kind of give you an idea as to what we've been working on together. I mentioned food pantries. Partnering with the current national network for flourishing in health, we've been able to offer a funding opportunity for participating medical schools to apply to an unmet basic need. The majority of these schools focus on addressing food insecurity by establishing or maintaining a food pantry, with some expanding on the capability of those food pantries. One school utilized the grant to purchase a refrigerator and allow for perishables in their pantry, elevating students' meal choices from granola bars to including protein, dairy. Multiple schools extended the capacity of their pantry to better support all health professional students. What else can we do to better support medical students? As I mentioned, offsetting their budget. One partner school will be utilizing the funds to supply their care closet, a collection of resources from professional clothing to accessibility related equipment that students can check out. Another partner school is aiming to purchase and loan clinical equipment for students, particularly focused on removing the cost barriers for first-gen low-income students who can't afford a stethoscope, an ophthalmoscope, an otoscope, many other tools that have a very high cost barrier, but as we're assured, are a good return on investment. And as I had mentioned, one partner school aiming to purchase adaptive equipment for students to utilize. Again, offsetting the many costs that students with disabilities face, wrist braces, lumbar cushions, and so on. That same care closet at that partner school will also include professional clothing or use-only study materials, things that can be returned and further loaned out. Again, promoting the reuse, recycle, and reupholster necessary for a functioning society. And lastly, expansion of wellness efforts. Some schools have utilized the funding to better understand the layers of food insecurity on their campus and how they could address it from a system level. See, I had mentioned 3 solutions, but it's very difficult to implement that when one partner school has 5 campuses over 5 states, and they're utilizing the grant funding to better understand what is driving food insecurity at particular campuses and how can they better support those learners. Another partner school is aiming to better understand student perception of possible interventions. So, as you can imagine, if I place the food pantry on a campus, students may not use it. And it's not because the food isn't that good, it's because they're afraid of who's watching. So it's really important in the implementation cycle to better understand how people will perceive this. And we've been fortunate to partner with such thoughtful members. And now I'm going to pass on to the next slide. You're welcome to scan it, but these slides are recorded to share other resources that you can consider. This multi-page document was compiled by other colleagues who've published this work in 2022 to reflect on what other basic needs and initiatives that your institution can implement to support their learners. I'm going to go on to my references and stop for questions.
Bassel, thank you so much for going over all of that information and reviewing the wonderful research the team has been doing. It really is heartening to hear all of these different numbers, really staggering numbers, honestly. For everyone joining us today, if you have questions and you would like to share them in the Q&A portion of your Zoom,